In this video, we're going to talk about passive accessory motion. There's a couple different ways to talk about this. And so there's the passive physiologic intervertebral motion. Sorry, I had to look at that so that way I said it correctly. It's a long word. But when I think about it, we have PPIVMs and PPIVMs. And so with these, what you're looking at is how everything is moving. And is it physiologic motion that we're talking about, or is it accessory motion? And with the accessory motion, we're going to talk more about just rotating the vertebrae themselves or doing anterior posterior types of motion with them. And with these physiologic ones, what we're going to look at is actually moving the spine into flexion, extension, and rotation. And when we do these, you can use them for lots of different purposes. One is just to really be assessing the range of motion that's going on within those individual intervertebral areas. So you're looking at the motion, say, between S1 and L5, and then L5 and L4, and on and on and on, working up, and or in all those different motions for physiologic stuff. And so again, flexion, extension, and rotation is what we look at. And so for this, you want your patient to be on their side, and it doesn't matter which side it is. If they have one side that's more tender than the other, it'd be better probably than have them lie on the non-tender side. But in general, it's not going to really matter because you're going to be moving them into flexion and extension and rotation. One of the things to think about is the height of the table. You don't want it too high because that's going to cause difficulty for you to be able to actually move your patient. You really need to be in a good position that your body's going to be able to support them, because you're going to have to be moving their trunk, and everything that you're going to be doing is going to be starting from the S1 L5 junction and then moving superiorly for all of the 3 tests that we're going to do. And so you're always starting down here and then working your way up, because you're either starting the opening here or you're closing from here and then continuing that as you move further into whichever direction, whether it be rotation, flexion, or extension. So let's start off with these first. The first one that we're going to do is flexion. And so again, if you guys remember, you can find your sacrum and come off your PSIS. But when you're going to do your palpations, it's usually pretty easy just to find your sacrum. It's that really nice flat bone, and you're going to feel that drop off between S1 and then L5. So as you're going to be palpating on those, you're going to find those little nodules that are going to stick out for the spinous processes, and then just put your fingers right on top of them. And that's how you're going to do all 3 of these: flexion, extension, and rotation. And you're going to start out on this position. And it should be right in the middle, right? Because that's where their sacrum and their spinous processes are. And so what you would do is have them in a nice relaxed position, make sure that they're in a good position, that they feel comfortable. I always have them slid all the way on the table. So one, I don't have to work so hard to move them into flexion and extension. And 2, I'm not having to lean way forward, because that puts a ton of pressure on your back and you can really hurt yourself, especially if your size and your patient's size are really off. So for instance, sometimes when I've had to work on like 6'7", 350-pound football players, doing this is a workout. So just think about what you're doing and how you're doing it, and what position for you and for your patient is going to be the most comfortable, but also from a strength and mechanics position for you is going to be the most advantageous. So again, you want them laying just straight on their side. So come up just a little bit. We find those spinous processes. And then to do the flexion, all you're going to do is put your hands up underneath their legs. And I tend to try to control them at the knees, because that's a much easier position to be controlling from. And you're not going to move them a whole lot, guys. Like, all you're doing is you have your finger on S1 and L5, and you are feeling for S1 to move, not L5. So what you're going to do is slowly move them into a little bit of flexion, and you can see my index finger move forward, right? And you move until you start feeling that L5 move, and once you feel that, then you stop. And then you move your index finger to L5, and then you move your middle finger, that's how I do it anyway, to L4. And so then you're going to flex them a little bit more and feel L5 move until L4 starts to move, and then you stop, and then you move up again. And you do the exact same thing through all of these, and what you're feeling for is, are they moving the same? Okay, they should have the same kind of end feel. They should be moving the same. Are they getting locked, or are they hypermobile, or some of them where you're really, really having to bend their hips and put them into flexion, and then the next one's moving? So you're looking for hypomobile, meaning that they're not really hardly moving at all, or hypermobile, meaning that they're moving extra compared to the rest of them that are behind them, okay? So then when we're going to go into rotation, this one can take a little bit more out of people, and you can do it a couple different ways. I recommend moving both legs, not just one of the legs. But again, you would start them in the kind of neutral position. You would come back and start again at S1 and L5. And then for rotation, all you're gonna do is actually rotate their legs up. And again, you're feeling for S1 to move a little bit, and this is totally passive, guys. And once S1 moves and L5 stays, then you move up, and then you rotate some more, and you feel for that L5 to rotate, and L4 should stay put, and then you come up a little bit higher. And I know that you guys can't really see me, but I have his like lower leg and his knee resting on my leg. So I'm using my body to support him, because you really need your patients to be relaxed when they're going through this, because otherwise, if they're feeling like they have to support themselves, you're not going to get a very good assessment. And then the last one that we're going to look at is going to be an extension. So again, you put them back into a neutral position where they're nice and relaxed. Put your fingers back where you were before, so you're on your S1 and L5 spinous processes. And then again, it seems kind of counterintuitive that you would always be starting in the same place, but think about, as we're moving, this is the area that's always going to open or close first, because we're moving up that way. So what you're gonna do is, again, just support them at their knees, and you don't even have to hold this one. You just come here, and then you're gonna slowly extend until you feel S1 move posteriorly, right? So it's gonna move into extension, and L5 is gonna stay put. Then once that happens, if L5 starts moving, you stop and go back to where it was. Then you come back to L5 and then L4, and then you move them a little bit more into extension, and you feel the L5 go into extension and L4 stays. Then L4 and L3. L4, I got it, L4, L3. And then you're gonna bring them back even a little bit more as you come through these. And so you're gonna feel the spinous processes actually come together as you move them more and more into extension instead of separating. What we felt in flexion is the spinous processes are spreading apart. When we're in rotation, what you're gonna feel is them kind of actually rotating on one another. And the lower one is gonna rotate on the more superior vertebral segment. So you're always looking for the bottom one to move on the top one as we're going through these.